All right, welcome everyone. In this explainer, we're going to do a focused clinical review of leishmaniasis. And I want to give full credit right at the top. All of this is based on the fantastic work of Dr. Mohammed El-Naji Mohammed.
Okay, so let's start right at the beginning. What exactly is leishmaniasis? Well, at its heart, it's an infectious disease caused by a tiny parasite, a protozoa from the Leishmania family. Now, these little guys are what we call obligate intracellular parasites. That's a key term. It just means they absolutely have to get inside our cells to live and reproduce. And how do they get to us? It all comes down to the bite of an infected sandfly.
Now, here's something that's absolutely crucial to grasp from a clinical standpoint. Leishmaniasis isn't just one single disease. Not at all. It's really a spectrum of different syndromes. We generally break it down into three main forms, and which one a patient gets really depends on two things: the exact species of Leishmania they're infected with, and of course their own immune response.
So here's how we're going to tackle this. We'll start with an intro, then dive into the cutaneous form, then the mucocutaneous form, and the big one, the visceral form, also known as Kala-Azar. Then we'll wrap it all up by talking about diagnosis and management. Okay, let's jump right in. We'll start with the cutaneous form, which is the one you're most likely to see. This is the localized disease, pretty much confined to the skin. So the first thing you need to ask is, where did the patient get this? Geography is everything here, and it has huge clinical implications. If we're talking about the old world, think Africa, India, you're probably dealing with Leishmania tropica. But in the new world, South and Central America, it's more likely to be Leishmania mexicana. And trust me, knowing this distinction is absolutely vital when you start thinking about treatment.
So what does this actually look like on a patient? The classic presentation is a lesion right at the site of the sandfly bite. It starts as this crusted sore that just won't heal. It's usually on an exposed bit of skin, the face, arms, legs. And here's a clinical tip. If you were to carefully remove that crust, you'd often find a classic-looking ulcer underneath.
Okay, so this is the so what moment. This is why that geography matters so much. If your patient got it in South or Central America, the New World, you have to treat it, and you treat it systemically. Why? Because you're worried about it progressing to the really nasty mucocutaneous form. On the other hand, if it's Old World disease from Africa or India, you can often be a bit more conservative. Sometimes those lesions will heal on their own.
All right, moving on. Now we're going to talk about what happens when things get more serious. This is the mucocutaneous form, and it's all about destructive progression.
The main culprit here is a species called Leishmania brasiliensis. And remember, this is a New World problem. The key feature, the thing that defines this form, is that the parasite spreads from that original skin lesion and attacks the mucosal tissues. And here's the scary part. This can happen months or even years after that first skin source seemed to have healed. So where does it go? The parasite has this nasty habit of zeroing in on the mucosa of the nose and throat. It sets up a chronic, progressive inflammation that literally eats away at the tissue. We're talking destruction of the nasal septum, the palate, the pharynx. It leads to horrible disfigurement and serious problems with breathing and swallowing.
Okay, now for the most severe form of all, the one that can be fatal. We're talking about visceral leishmaniasis, or as it's more commonly known, Kala-Azar. This is a systemic disease. The name Kala-Azar actually tells you something important. It means black sickness. And that's a direct reference to a clinical sign you can see in advanced cases, a characteristic grayish, dark discoloration of the skin. The parasite that causes this systemic form is mainly Leishmania donovani. And you can see from this, it's not some rare, isolated disease. It's a global problem. You find it in the Mediterranean, across Asia, in South America, and in Africa. So what does a patient with Kala-Azar look like? Well, they are sick. Think of a severe systemic illness. They'll have these long-lasting fevers, drenching sweats, and chills. And when you examine them, the absolute hallmark finding is a massive spleen. We're talking huge splenomegaly. Often the liver is enlarged too. And all this goes along with profound weight loss and a really poor appetite. But here's a really interesting clinical pearl, something that can trip you up. While most patients have a poor appetite, occasionally you'll get someone who tells you they're starving, that their appetite has actually increased. And this is happening while they are clearly wasting away. It's a weird paradox, and if you're not aware of it, it can definitely send you down the wrong diagnostic path. So what's happening on the inside?
All those parasites invading the spleen make it go into overdrive. This is called hypersplenism. The spleen becomes like a giant vacuum cleaner, sucking up and destroying all the blood cells, red cells, white cells, and platelets. The result? Pancytopenia. And that explains so much of the clinical picture. The anemia causes fatigue, the lack of white cells leads to infections, and the low platelets cause bleeding.
All right, let's pull all this together. In this final section, we'll talk about how you actually diagnose these conditions and the principles of how we manage them. Okay, so to make a definitive diagnosis, you need to see the parasite. You need tissue. For the cutaneous form, this is pretty straightforward. You just do a punch biopsy from the active, raised border of the lesion. But for visceral disease, it's a whole different ballgame. It's much more invasive. The gold standard is to get a bone marrow or a splenic aspirate to find the organism. Now, the splenic aspirate is more sensitive, but it also comes with a higher risk of bleeding, so that's a clinical decision you have to weigh.
When it comes to treatment, the historical go-to has always been a class of drugs called pentavalent antimonials, like sodium stibogluconate. That's been the first line for a long time. But, and this is a big but, we're seeing more and more resistance. So the field has really moved towards using liposomal amphotericin B. It's become absolutely critical, and in many places it's now the preferred first-line treatment because it works well and has a much better safety profile.
So let's end with a thought-provoking question. We tend to think of leishmaniasis as a tropical disease, something you see over there. But think about it. People are traveling more than ever. Our climate is changing, which could expand the sandfly's habitat. So the real question for all of us is this. Are we, as clinicians in supposedly non-endemic areas, ready for this? Are we prepared to put leishmaniasis on our differential when it walks into our clinic?